And if we had that same message given to us about how important the pelvic floor is, 95% of women with low back pain have some form of pelvic floor dysfunction. And we're going to see chiropractors and massage therapists and acupuncture, and all of those can absolutely play a role and help. But so often it's the pelvis, it's the pelvic floor.
Welcome to Suburban Warrior, the podcast that will impact, inspire, and empower you to transform your mindset and become the badass warrior that you are. I'm your host and fellow warrior, Chrissy Pfeiffer, former clinician and corporate marketing exec turned multi-passionate entrepreneur, performance and life coach, and mom to 4 not-so-little warriors. Each week, I will bring you honest conversations with inspiring guests to share their stories of resilience, optimism, success, and simple yet effective strategies so that you transform your thoughts and change your behavior to get the results you want in your life. You will be empowered to take action, warrior up, and believe in you. Let's do this. What's up, warriors? Welcome back to another episode of the Suburban Warrior Podcast. I'm your host, Chrissy Pfeiffer, and I am here with another amazing suburban warrior here to share her story and expertise with you again this week. And this one is going to be a good one, ladies. I think it's going to be spicy because we are talking all things vaginas. And I think we're going to say that word about 1,000 times on this podcast today because I am here with the Vagina Coach. So let me introduce to you Kim Vopni. She's a personal trainer and menopause support practitioner known as the Vagina Coach. She became passionate about spreading information on pelvic health after the birth of her first child over 20 years ago. Kim is a seasoned and passionate speaker, a women's health educator, and the author of 3 books. She began her work with the prenatal and postpartum population, where she founded her own business and co-founded a second company called Bellies. She now works primarily with women in the perimenopause and postmenopause phases of life. Her Buff Muff membership is an ever-growing community where people from around the world find support through her workouts, challenges, and group coaching. Kim also certifies other fitness and movement professionals to work with women with core and pelvic floor challenges. You can find her online through her podcast, Between Two Lips, her website at vaginacoach.com, and on social media at Vagina Coach. Welcome to the podcast, Kim.
Thank you. Thanks for the intro and thanks for having me.
Absolutely. I am very excited to have you on because as a woman in menopause myself, surrounded by many women that are in perimenopause or menopause also, I know we talk about a lot of things perimenopause related. I mean, the symptoms, we could go on and on, so, discussing all those things. But, one of the things that we don't talk about enough, I think, is our vaginas, right? There's a lot going on there throughout the whole course of our life. Like you said, starting from, having kids, then throughout, perimenopause, menopause. And I think it's like the one area where it's sort of, people don't tend to talk about all of the wonderful and terrible things that are going on there. So I'm really excited to have you on the podcast so we can really do a deep dive into this topic. So first, why don't you tell us a little bit about yourself?
Yeah. The journey to become a vagina coach is not something that I was dreaming as a child, what am I going to be when I grow up? That wasn't on the list.
The Buff Muff wasn't on your
It wasn't on my list.
Yeah.
No.
Okay.
So, however, I would say I remember being in 6th grade and seeing a childbirth video, and it was part of our sexual health education. And I thought, nope, not going to do that. And I went home and I looked at my mom a little differently, and I looked at all the women in my life and I thought, well, they did it. So I had sort of this fear and fascination about pregnancy and childbirth, but I was pretty adamant all through my teens and into my 20s that I was never going to have kids.
Right.
And over that time, I saw that video, and then I eventually saw my mom stop running because she was leaking urine. I saw her struggle with back pain. She had a tummy that would never flatten. She had a hysterectomy. And so I saw her pelvic health journey as ways it was essentially confirming, nope, I don't want to do that.
Right.
And then when I got married and decided I did want to start a family, I was fortunate enough to witness my sister-in-law give birth. And that was the first time that I had seen anything other than what we see in the media. And it was a normal physiological birth. She was supported by midwives. She was in a side lying birth position. She did not have any tearing. And I remember the next day looking at her like, is everything falling out of you because I saw how big your vagina was? And she's like, no, it's a little sore, but no. And I thought, okay, that's different than anything that I have envisioned. It's different than that 6th grade video that I have seen. It's different from anything in the media. And the following year, I was pregnant. And now I was doing as much investigation or research as I could do to have a story similar to my sister-in-law rather than my mom, who had had episiotomy births. And through that journey, my midwives had recommended a product to me called the Epino. This is a biofeedback device from Germany. It was a doctor from Germany in Africa who watched women in Africa using gourds of increasing size to prepare their perineum and their pelvic floor for birth. And he thought, well, that's great, but that's not going to fly in North America. So how can we make this more mainstream? And he worked with a team of doctors and physiotherapists and midwives to create this medical device called the Epino. And Epino stands for no episiotomy. It's currently not available in North America. Unfortunately, it is in Europe and Australia. I was fortunate at the time to be able to purchase one. I used it. I had a great experience. And I thought, why doesn't everybody use one of these? And I ended up becoming the Canadian distributor and was the Canadian distributor for 14 years until Health Canada, which is equivalent to the FDA, implemented a new medical device licensing procedure that made it a lot more costly and had a lot more hoops to jump through. So the manufacturer in Germany decided to leave Canada. That's just a bit of a sidebar. But essentially, my use of that device is what brought me into this world of learning the term pelvic floor, understanding that this is a group of muscles that can be trained, and why haven't we been taught anything about this? So that is the seed really that got me to the point of I became a distributor for that product. I ended up having an e-commerce store with other pelvic floor related products, mainly focusing in the pregnancy postpartum space, because that is a very well-established risk factor for pelvic floor dysfunction. So if we get the education to people ahead of time, could we make changes? That's where it started. Then I was recognizing that we in North America grossly overlook the need to recover. And we spend 9 months glorifying our belly. We wear all these clothes to emphasize our belly. We compare it to fruits and vegetables. And then as soon as we are a mom, now the belly becomes a place of shame. We have to not look pregnant as fast as possible. And when there's no regard given to the need to recover. So I wanted to change that. Formed a company called Bellies Inc. We wanted to take influence from other cultures around the world who do honor the postpartum recovery phase and bring it to more modern day practices. So we designed and manufactured a postpartum wrap, coupled it with pelvic floor exercise. That business has been sold. It still exists, but no longer in my hands. And then through the journeys of growing these two companies, myself and I had two business partners in Bellies Inc. We were going through our own perimenopause journey. And then now there's this other whole host of things that we need to consider. And we thought, this is not just do your Kegels in pregnancy or here's how you recover more optimally. This is a journey that all women will go through. Not everybody will become pregnant and give birth. We will all, if we reach midlife, go through menopause.
Yeah.
All of us are at risk of pelvic floor dysfunction, whether or not we've given birth or not. And so that then kind of opened up this other chapter. And along the way, we created a certification course because we recognized that as one of my partners was a physical therapist, the other one was a personal trainer, and never in our fitness education, where we learn about every other muscle in the body, did we learn about the pelvic floor, the foundation of the core. We learned all about the core exercises, but we didn't learn anything about the pelvic floor. And so we needed to change that as well. So that's kind of long story. How initially, actually, I was called the fitness doula because I had trained as a doula. I was working primarily with prenatal postpartum. And then as I started to work more with perimenopause, menopause, doula wasn't resonating so much. And so I think it's about 7 years ago now, I was presenting to a group of women entrepreneurs, and everybody who was at the conference speaking was some sort of a business coach, marketing, strategy, SEO. Yeah. And then I get up on stage and I said, jokingly, now you have a vagina coach for your business. anyway, that's where the word Vagina Coach came from, and it kind of stuck.
I love it.
Yeah, and here we are.
And here we are. That's a great story because, again, it's like necessity is the mother of invention, right? Throughout your life, you saw where the gaps in the market were and tried to fill them. And I think, you're right. I mean, so my background, I'm a nurse, and I don't really even remember getting much training about the pelvic floor and really nothing about pelvic floor dysfunction. Really, it's just not something that we talked about in medicine and in the medical field. So, and now I come to realize that there are literally physical therapy offices that are just for pelvic floor dysfunction. So there's obviously a need out there. There is a need for not just those who have pelvic floor dysfunction, but I think also those to just be educated on what our pelvic floor does and what are the symptoms. So let's just talk a little bit about the pelvic floor quickly so that my listeners can understand sort of what we're talking about. Because, like, what is pelvic floor dysfunction?
Mm-hmm. So the pelvis, if you're sitting or standing, if you put your hands on your hips, that's the top of your pelvis, and the front bones, those are your ASIS, and then if you bring your fingertips down to what most people refer to as their pubic bone, it's actually a joint there, but so there's an intersection of two bones there, so that's one attachment point of your pelvic floor muscles. Okay, so your pubic joint at the front is one attachment point. Then if you're sitting and you lift up one butt cheek and you pry the flesh away, you should be able to dig in there and find a bit of a bony point through your butt cheek. That's your ischial tuberosity or sits bone. We have one on either side. Your pelvic floor muscles attached there. And then at the base of our spine, we have the triangular bone called the sacrum. And at the very tip of the sacrum, we have another little joint and a bone there called the coccyx or the tailbone. Yeah. That is another attachment point for the pelvic floor. So the pelvic floor is a group of muscles that attach to those 4 points. They make sort of a diamond shape, if you can kind of imagine that. There's 3 different layers. So we have the initial first layer that primarily is responsible for our sexual response. The second layer primarily responsible for managing the openings of the urethra, the vagina, the anus. The third layer is primarily responsible for supporting our internal organs, the bladder, the uterus, the rectum, intestines, urethra. And that doesn't mean that it's only that one level, but these 3 layers work together. There's a huge blood flow. It's highly vascular. There's a lot of nerves within the pelvis, but it's multiple muscles in multiple layers. It's not just one pelvic floor muscle. So that's important to note. Mm-hmm. And it's really the floor, the pelvic floor is closing off the base of our pelvis. Male and female anatomy. Males have a pelvis, males have a pelvic floor. Their pelvis is narrower and taller. They don't have a vaginal opening. They don't have a uterus. They don't menstruate. They don't have the same hormonal fluctuations. They don't become pregnant and give birth. So we, having female anatomy and going through all of the different hormonal fluctuations, most of us becoming pregnant at some point in our life, if we reach midlife, we all go through menopause. All of those put us at increased risk of pelvic floor dysfunction. The most common types of pelvic floor dysfunction there's pain. So pubic joint pain, tailbone pain, hip pain, painful sex, vulvodynia, so pain in and around the vulva, vestibulodynia, pain at the opening of the vagina, dyspareunia, painful sex. There's so many different types of pelvic pain. Endometriosis, adenomyosis, bladder pain syndrome. There's lots of different pain categories. There's also incontinence. So there's stress urinary incontinence. That's where we laugh, cough, sneeze, jump. Some sort of exertion creates a leak of usually just a few drops of urine. There's urgency incontinence or urge incontinence where we are fine, but a trigger happens, sound of running water, key in the front door, thinking about a bathroom, and all of a sudden alarm bells go off and we feel like we can't make it to the bathroom in time. And we may leak a little bit of urine or we may have a complete release of the bladder. We can have a combination of those two, which would be mixed. We can have anal incontinence, so gas or stool leaking out. Then we have, actually, one more thing I'll say is people will often say they have an overactive bladder or I have a small bladder. So people who say they have to go to the bathroom all the time, frequency. There is a medical term called overactive bladder, but a lot of people just use that term because they go to the bathroom all the time, not knowing the reasons why they're going to the bathroom all the time or waking multiple times a night to pee. And then we have prolapse. And prolapse is statistically more common than incontinence, yet we hear nothing about it. Incontinence we hear about because the pad companies tell us it's just part of being a woman, and you just have to put on this crinkly black underwear and get on the back of a motorcycle with a handsome man and everything's fine.
Exactly.
Yeah. So prolapse is where the bladder, the uterus, and the rectum or the rectum will shift out of their optimal anatomical position, and they can bulge into or descend into the vagina. So in the case of a bladder prolapse, it starts to bulge into the anterior wall of the vagina. In the case of the rectum, it can bulge into the back wall or the posterior wall. And in a uterine prolapse, the uterus and the cervix descend from the top down. Those are the three most common. 50% of women who've given birth will have some degree of prolapse.
Yeah. I mean, makes sense. And is the solution to prolapse and to a lot of these other symptoms strengthening and training the pelvic floor?
That's one aspect of it. And most people, when they think of strengthening, they think, I need to tighten.
Yeah.
So we equate strength with tightness.
Yeah.
But tight muscles are weak muscles. And it seems to be more and more people have much more tightness or tension in their muscles than what would be considered optimal. So people think, well, if I have tight muscles, how can I leak? If I have tight muscles, why is my bladder bulging? But tight muscles, again, are weak and they can't react at the right time. They don't produce the adequate force. They can't do all of the jobs of supporting the spine and pelvis, managing the organs, managing those openings, controlling our movement if they can't generate force and if they can't react at the right time. So strengthening, yes, but strengthening doesn't mean just let's do 1,000,000 Kegels a day.
Right.
We've also never been taught how to do Kegels correctly. Many of us have heard the term and we know we should be doing them, but no one's ever evaluated our pelvic floor and told us what would our pelvic floor benefit from. And most would benefit from some form of Kegel type, like voluntary activation and relaxation. But when you've never been taught, never had your pelvic floor evaluated, maybe you've been given a brochure, you don't do them correctly. And we have evidence to show that the majority of women do them incorrectly, and then they think they don't work.
Yeah.
And so
is there a right way to do a Kegel for everybody?
A Kegel is a voluntary engagement, so contraction and lift and release of the pelvic floor. Okay. Most people interpret Kegels as squeezing, and often they will squeeze their glutes or they'll squeeze their inner thighs. They sometimes bear down and hold their breath thinking they're activating their pelvic floor.
Right.
But so gold standard to determine if you're doing them correctly would be to see a pelvic floor physical therapist. You'd mentioned that you see them, and yes, they are the most underused women's health resource that we have.
Yeah.
So seeing a pelvic floor PT would be what I consider to be the gold standard to see if you're doing them correctly. But generally, if you were to insert a finger, it's difficult when it's our own finger because we have to be in a bit of an awkward position to be able to feel with our own fingers. But if you happen to have a partner with their fingers, or if your partner is male and has a penis, that can be your biofeedback. So when that is inserted, what the partner or what you would be feeling for if it's your own fingers, you should feel a gentle hug and almost like a little bit of a drawing up. You're not trying to pull it up to the top of your head, but you just feel like a general upward motion.
Yeah.
And then there should be a release of that. And so many people can't feel the release. They have a hard time letting go. But that's arguably one of the more important parts, is being able to release tension and allow the muscles to be at their optimal resting length. So strengthening, quote unquote, the pelvic floor is often about unleashing the strength by releasing tension. So that's one component. We, yes, want to release tension. We want to be able to voluntarily activate, lift, and let go. But newer research supports my bias, which is we need to train the pelvic floor dynamically. Kegel exercises, which is the voluntary contract, lift, let go, are typically done lying down or Some people do them at every red light, or they do them while they're brushing their teeth. And while that is better than nothing if you're doing them correctly, it doesn't train the pelvic floor upright against gravity, moving, lifting, pushing, coughing, sneezing, all the things where symptoms are typically showing up. And newer research is showing that Kegel's done prior to a resistance training program or as part of a resistance training program is superior to Kegel's alone. And it also goes like it's a much bigger topic than just do some Kegels with your resistance training. We have to look at our posture. We have to look at our breath. We have to make sure we're staying hydrated. We have to make sure we're pooping well every day. We want to make sure we sleep. We want to make sure we don't have footwear that changes the position of our pelvis. Like there's so many things which can be overwhelming, but I tried to present it as these are all opportunities we have to improve the way that our pelvic floor functions for activities of daily living, and also just, to help us age powerfully.
Yeah. Yeah. Because a lot of symptoms that you mentioned, whether it's painful sex, back pain, some type of incontinence, that sort of thing. I think a lot of people don't really think pelvic floor when they think about all of these symptoms that they could be having that, could be coming on in perimenopause because of, there's not as much blood flow. I know you can have a hypertoned pelvic floor, to your point, so that everything's too tight, and causing pain. Then too loose, that's a problem too. But I think that what's fascinating is that the pelvic floor is involved in so many different aspects of our body, that we're not really aware of. All of these different organs. Obviously it's the vagina, but the bladder. To your point, back pain, hip pain. All of these things that I don't think as women we're thinking like, oh, this could be
the pelvis.
Because it's the pelvis. Is this really, and while, we might go see a physical therapist because our knee hurts or we injured our knee, I don't know until someone, I guess maybe a doctor prescribes it, or, people aren't thinking like, oh, I need to go see a pelvic floor physical therapist.
Yeah.
It recently came to my attention that was even a thing within the last year, which I think is amazing. And I agree with you that I think it is one of the most underused women's health resources that we have, versus, maybe going on all these, other prescription medicines. And, this is something that they could try first.
1,000%. So many women are offered pharmaceuticals. They might be offered medication. They might be offered surgery for incontinence, for organ prolapse. They might be offered a hysterectomy. In perimenopause, we have heavy bleeding, and so many. That's one of the top 3 reasons why people have a hysterectomy. And nobody is given any counsel on the repercussions of a hysterectomy from a pelvic floor perspective. It increases your risk of prolapse. It increases your risk of incontinence. It can influence your sexual health. It can influence your posture. And nobody is ever told that. And so if we had this seed planted earlier in life, I always equate it to the dentist. We, from a very young age, we're taught to brush and floss, and we see our dentist once or twice a year for a checkup. And we will faithfully go to that checkup, even if we don't have a toothache, and even if we have no bleeding gums or nothing. We just go. And if we had that same message given to us about how important the pelvic floor is, 95% of women with low back pain have some form of pelvic floor dysfunction. And we're going to see chiropractors and massage therapists and acupuncture, and all of those can absolutely play a role and help. But so often it's the pelvis, it's the pelvic floor. And if we had that seed planted that the brushing and flossing is the pelvic floor exercise and posture work that we do, we then go to our pelvic floor physical therapist once a year for our checkup. They help screen for the cavities, which would be like the prolapse or the incontinence or the tissue changes. And they can help us intervene early, so we could help prevent that from advancing. We could potentially even reverse it completely. But so often it's not what we talk about, and we just deal with it, and we put up with these symptoms, and we are told by media that it's normal, and we might even be dismissed by a care provider. Well, that's what happens after you have babies, or that's just a normal part of aging. And then people are sent down this path of pharmaceuticals and surgery, which I don't want to take away from the role that they can play, but they should definitely not be our first line of defense.
Exactly. there are people that are certainly candidates for that, but to your point, it's just, should it always be first line? And I think that, again, as women too, we're so willing to talk about our back pain or our hip pain, but we're not talking about our vaginas, and we're not saying that we're having painful sex, and we're not saying, whatever, we're incontinent.
Yeah. Yeah.
um, okay, so let's talk about perimenopause and menopause. What would you say are probably the top symptoms that your clients who are in perimenopause or menopause come to you with?
Leaking, urgency, waking multiple times a night to pee, pelvic organ prolapse, and painful sex.
Okay. So my next question is the solution to that, to all of those issues, are they all different?
They all have a similar combination of approaches.
Okay.
So there isn't one magic exercise for incontinence. There isn't one magic thing for prolapse. There's a combination of a few things
for each of them.
So,
well, let me ask you about painful sex. Let's talk about that, because that is one that I hear from a lot of, perimenopause and menopausal women. And everyone thinks it's just because they get dry, which makes sense. And maybe that is exactly why. But are there other things going on besides just the fact that we don't have as much blood flow and we're not as lubricated?
Yeah. Estrogen plays a huge role. So there's a whole category of symptoms called genitourinary syndrome of menopause, GSM.
Yeah.
And we have genital symptoms, we have urinary symptoms, we have sexual symptoms. And so painful sex is in there. And yes, it could be from low estrogen, meaning the tissues are thin and dry, and that's why it hurts. That is absolutely one reason. However, there's also, maybe it's tight muscles. Tight muscles are going to restrict blood flow and circulation, and they're going to make insertion. If that's part of your sexual health practice, then that will be challenging. There's also prolapse. If somebody has a bulge into the vagina, that could create some discomfort with especially insertion. There's the pain. So if somebody has tailbone pain, pubic joint pain, low back pain, that could also endometriosis. If they have other kind of pain is often as a result of inflammation or can create inflammation, and the inflammation can create other pain sensations. So we want to be able to understand, why do you have pain? It could also be, there's a condition called lichen sclerosis, which is, it can present with similar symptoms to GSM, but it's an autoimmune condition that will affect the tissues. It's not curable. We can manage it, but if you aren't being screened for something like that, that could be part of the reason why you have pain. So seeing a pelvic floor PT can help you screen for the tight muscles, can help you screen for position of the organs, can help you screen for the tone in your muscles. Is it balanced? Is one side tighter than another? Could be scar tissue related. Somebody who maybe has had episiotomies or tearing from childbirth, or maybe had another pelvic surgery, maybe he's had a hysterectomy. Hysterectomies can change sometimes the length of the vagina. The scar tissue from the procedure can create issues. So it's very multifaceted. Estrogen, yes, is a big player. And I always say, from the start of menopause onwards for the rest of your life, I consider vaginal estrogen to pretty much be an essential nutrient. I know it's not a nutrient, but I use that terminology.
Interesting. I like that terminology. That's pretty good. I like that. So for those people that don't know, tell us what vaginal estrogen is. I mean, I'm aware of what it is, but tell my listeners what vaginal estrogen is.
So estrogen is like our juicy hormone. We have boatloads of estrogen in our bodies during our fertile years. And as we are approaching menopause and moving post-menopause, we have a steep decline, and we no longer then produce very much estrogen. And like estrogen affects our entire body. We're going to talk specific to the pelvis. That's what our topic is today. So the walls of the vagina, which typically have folds in them called rugae, without estrogen, the tissues become thinner and drier. And I equate it to, I don't even remember who said this initially, but I love this visualization. It was a pelvic floor physical therapist I heard in a presentation. She said, it's like a pleated skirt going to a pencil skirt. Those folds are becoming less, and part of the part of the function of those folds is allowing things to come in and out. It's the expansion and recoil. It
Yeah.
helps. It's the juiciness. So the tissues become thinner and drier. In an extreme case, the walls of the vagina, the opening of the vagina can actually close. So vaginal atrophy is a terminology that is used for thinning, drying tissue.
Yeah. That's a terrible term.
It is a terrible term. And
It's
thankfully but
terrible. No,
GSM is also a bit of a mouthful, but it
yeah.
is a more
Yeah,
encompassing term.
totally. But nobody wants to hear they have vaginal atrophy. I
No,
mean, that
no.
is just terrible. But okay.
And
So
it's not indicative of all of the things.
right,
There's
right,
so
right.
much more going on. So, but atrophy is a term that is used for the shrinkage, basically,
Yeah.
of the tissues that becomes very painful, thin, dry. So we
Yeah.
can have burning, irritation, that type of thing. The external genitalia, the labia, can also, so we can start to lose our lips. So if we're using something like vaginal estrogen, it's vulvovaginal estrogen. So we want to make sure we're applying it on the external tissues as well.
Okay.
The inside, closer, like around the bladder, a lot of the urgency, frequency, the quote unquote overactive bladder sensations, or sometimes even
Yeah.
burning with your urination.
Yeah, like almost indicative of UTIs. Like
Yeah,
those
and
symptoms that yeah,
so it feels like a UTI, and oftentimes it will become a UTI. So we are at
right.
much greater risk of UTIs post menopause because
Yeah.
part of the role of estrogen is to help maintain the pH of our vagina. So typically we have an acidic pH. That's acidic vaginas help us fend off infections. And when we don't have estrogen, our pH starts to rise. It's more alkaline. It doesn't fight off infection very well. Recurrent UTIs is a huge, huge problem.
Yeah.
And I get so angry when people in my community are 60, 70, 80 years old. They've been dealing with frequent UTIs for years, put on multiple antibiotics, and nobody has offered them vaginal estrogen. It drives me bonkers.
Nuts.
So
Nuts.
vaginal estrogen is estrogen that it can be in the form of a cream. It can be in the form of a tablet that's inserted into the vagina. It can be in the form of a ring pessary that would be inserted and left in for a period of time and then replaced. You can choose, some people use a combination of a cream externally and a tablet internally. It can be estradiol. It could be estriol. In Canada, we have one that's estrone. So there's three main types of estrogen. Estriol is primarily produced by the placenta when we're pregnant. Estradiol is our most potent, abundant form. And then estrone is primarily produced by the fat tissue post-menopause. And estriol is very anti-inflammatory. Estrone is more pro-inflammatory. Most of the research is mostly done on estradiol.
Yeah.
Sometimes people have a combination of the two, bi-est, which is a bit of estradiol, a bit of estriol in different combinations. And so it's about the delivery method, delivery mode. Do you want cream, tablet, or just put it in and forget it for a period of time and get it and replace it? I like the cream because you can use it internally, externally, because again, the external tissues need estrogen, benefit from estrogen as well. But some people don't like the mess of it. So you play around. It's a prescription, so you get it from your doctor. I am biased based on the evidence to bioidentical hormone therapy as opposed to the non-bioidentical. Bioidentical means it's the same chemical structure as what our bodies produce. And again, I consider it essential from the start of menopause for the rest of your life.
Yeah. And for those, obviously the conversation around hormone replacement therapy has gotten a lot louder in the last couple years. Thank goodness. When I started going through menopause, I could not find a doctor anywhere that would prescribe me any type of hormone replacement therapy at 43 years old. And then 5 years later, when I finally did, she said to me, I think it's malpractice that no one would give you any kind of hormone so young, because I had so many issues. But regardless, for those who might be experiencing symptoms, aren't ready to go on, a systemic estrogen, I think a vaginal estrogen is a wonderful choice for some of those genitourinary symptoms, like painful sex, like recurrent UTIs, like, all the things we were talking about, because it's localized. What are your thoughts on that versus, a systemic versus the vaginal estrogen? do you feel like it's a safer choice?
Estrogen is safe. I think
Yeah.
part of the message is I want to make sure that people understand that there was a lot of misinformation from the Women's Health Initiative that created a lot of fear and gave estrogen a very bad name. Estrogen is very safe and can be very protective, health protective, improve our health outcomes post menopause. So I just want to make that clear. There is local vaginal estrogen, which is very low dose. It stays and acts locally in the tissues. It does not go systemic, or very little does. So it will not give you the bone protection, the heart protection, all of the other reasons why we would use hormone therapy, systemic hormone therapy. Systemic hormone therapy is what will help with the hot flashes, which will help with our cardiovascular disease risk, help with osteoporosis risk, like all of that's the whole body. Not to say that it won't do anything for the vulvovaginal health, but it won't do a lot. We need the local estrogen. So it's two different conversations. And
Gotcha.
people will use both, myself included. I use vaginal estrogen. I also use systemic estrogen. Because I have a uterus and I'm using systemic estrogen, I also need to take bioidentical progesterone.
Progesterone, yeah.
But even if somebody did not have a uterus, so if somebody had had a hysterectomy, they may be told, oh, you don't need progesterone because we don't need to worry about the lining of the uterus. That doesn't mean that you would not benefit greatly from progesterone.
Yeah. Amen. I agree wholeheartedly with everything you just said. And I think it's a message that needs to be yelled from the mountaintops.
Yep.
I am hoping that more and more women find practitioners, whether it's a doctor, functional medicine, a health coach, someone to help them through their journey and educate them, specifically to what their needs are. Because I do think there's a lot of really amazing resources out there. And it's interesting to hear too that, I love the idea that you think that both are needed because they're really functioning and working in two very different ways.
Yeah.
For different symptoms. And not everybody may need both. But if you're in it and you really have all of these symptoms, that's
and I had the question in my own group coaching call today. Somebody said, does everybody need bioidentical hormone replacement therapy? So there's many different terminology: hormone replacement therapy, right, menopause hormone therapy, BHRT, bioidentical hormone replacement therapy. It gets confusing, but I could make a case that most people would benefit from it. When you look at the evidence and you look at our health risks post menopause, I think there's a very compelling reason for using hormone replacement therapy. Again, and most medical providers now who are prescribing will use bioidentical hormone therapy.
Right.
So I do think that there is a place for hormone therapy in a lot of ways. A big one is osteoporosis risk. It is the number one indication for the prevention of osteoporosis when started in the first 10 years post-menopause. The sooner we start, the better. And in the world of pelvic floor, many people who are leaking, who have prolapse. Some of them may have self-removed themselves from exercise because they think it's going to make things worse. Some of them may have been told not to lift anything over X number of pounds. Don't jump, don't run, don't do this. So don't. And their risk. So if they were not on hormone therapy and they've stopped exercising, we lose 10% of our bone mass in the first 5 years post-menopause. That person is at significant risk for osteoporosis. And we also know that incontinence and organ prolapse are independent risk factors for hip fracture. So for the bone protection alone, it is huge, especially if you have not been an exerciser, you haven't gone through building your peak bone mass in your 20s and 30s. That's a huge kind of passion of mine now, in addition to the pelvis, is the bone health piece, because so many people are not doing the appropriate exercise for their bones because of their pelvic floor. So let's establish a really strong pelvis, pelvic floor, core, that whole foundation, so that we can do impact, so that we can lift heavy things.
Yeah, absolutely. Okay. So if there was, I should say, besides reaching out to you, if someone is having some pelvic floor issues and they're listening to this and they have some of the symptoms and they're like, could this be my pelvic floor? Maybe, maybe not. Are there like one or two things that you could recommend that people could do right now or that everybody should be doing for the health of their pelvic floor? Are there like one or two top things that you would recommend that we do to keep our pelvic floor healthy or to help maintain our pelvic floor? Any advice for us in that?
So make sure you have enough water in the day. I recommend 2 to 3 liters of water. A lot of people who experience pelvic floor dysfunction stop drinking because they think that if I don't drink, then I won't have urges and I won't leak and that everything will be fine. But they end up becoming very dehydrated, which has a whole host of challenges, not including constipation.
Yeah.
Constipation is a huge contributor to pelvic floor dysfunction. So if you are not pooping well, if you are constipated, you will have more urges. You will have to go more frequently. And if you're straining to get that poop out, you are increasing your risk of prolapse. And if you already have prolapse, you're going to be making it worse. So water and poop are the first two things that I cover with people. So 2 to 3 liters of water, eat adequate fiber. I love Dr. Will Bulsiewicz, who's the author of Fiber Fueled. He talks a lot about gut health and poop, and it's not just about eating more fiber or taking a fiber supplement. And in fact, people who, especially if they're not drinking enough water, if they just start taking a fiber supplement, they will create cement and it'll make it even more challenging. So those two are top of the list. Another one that a lot of people don't think about is footwear. I recommend people transition to minimal shoes. The elevation of our heel. So the terminology would be positive heel, and that doesn't have to mean high heels. Most common standard running shoes have a positive heel, meaning our heel is higher than our toes. Small, like very small little increments of that heel lift, so to speak, changes the whole chain. Like our calves become shorter, our hamstrings become shorter, our pelvis has to adapt. We are more in a posterior tilt. And all of that is less favorable for managing our intra-abdominal pressure, for managing incontinence. There's research to show that the different elevations of heel. So if you have a neutral or even a heel drop, so there are some shoes, Lems is a company that has, I have no affiliation with them, but when the heel is actually lower than the toes, those are more favorable for pelvic floor, like to actually activate the pelvic floor. When our heel is elevated, so in high heels or even in like positive heel running shoes, it's less favorable from the ability to perform max voluntary pelvic floor contractions. So transitioning, and I emphasize the word transition. You're not just going to go run out and say, Kim said, get a minimal shoe and go get one and then wear it for the rest of your days. You need to, just like exercise, you need to slowly adapt. So you're going to get a pair of them and you will wear them for half an hour for a few days, then increase to 45 minutes, then to an hour, and spread it over months before you are actually spending all of your days in a minimal shoe. A great website is called Anya's Reviews, ANYAS reviews.com. So she is a barefoot or minimal shoe enthusiast, and she reviews all the different companies and talks a lot about minimal shoe and foot health. So that's one that people don't think about. Changing the footwear can make a huge difference in your pelvic floor function.
Yeah, I mean, is the human body just like the most amazing thing ever or what? Because here we are talking about pelvic floor health, and yet our shoes that we wear every day and what we're walking around in could be a contributor to all of these other symptoms that we're talking about, which is so just bizarre and amazing at the same time. I mean, I've never even heard of a minimal shoe. So that's something new for me. I'm excited to sort of check that out, but that's something I never thought about. Because I would think that, I mean, I know, wearing high heels and walking around in those isn't obviously probably the best for, your back and all that kind of stuff, but I would never have thought that even just like walking in sneakers could possibly be irritating my pelvic floor.
Yep.
Wow.
Crazy.
Wow, that is fascinating.
Yeah.
Well, Kim, thank you so much for joining us on the podcast today. I mean, I certainly have learned a lot, and I'm sure my listeners have as well. I think this is a topic that we could talk for a lot longer about because it really is fascinating. And again, I don't think there's a lot of information out there on it. And I think it's something that, especially as women, we all need to be aware of. We all need to tap into our pelvic floor. I think we need to think about all these symptoms that we're having, that it could be, partially related or involved. Once again, just always be advocates for ourselves when seeing healthcare practitioners, because sometimes just asking the questions, about pelvic floor or about, could this play a role, might shift an entire conversation when you're at the doctor. So
Yeah.
thank you so much for joining us today.
You're welcome. Thanks for having me.
Yeah, absolutely. And guys, you can find Kim again on her podcast, Between Two Lips. Her website is vaginacoach.com and on social media at Vagina Coach. So make sure to check her out. We'll have it also linked in the show notes. And you can find me at Suburban Warrior on YouTube, Instagram, and TikTok. And I want to thank you again so much for being with us today. Be sure to follow the podcast, rate, and review, and we'll see you again next week. Thanks, guys.